Hello again, it's John Muir and Joan Evans. We want to discuss the third session in communication skills, which will be held in the medical school in the Tupper building. And this session is the introduction to the content of the medical history. As part of this session, we will be handing out the content of medical history card to the students so that they have this. And I'm just reminding you that this is not an all-inclusive all they need to know card. It's a card with some of the common complaints that patients may have put into patient-centered language. So instead of asking, what are we, do you have dyspnea? No. Have you experienced any breathlessness? So that it's put into English rather than medical jargon. So many of the books that describe the medical interview, the functional inquiry questions are all put into medical jargon. And the danger of that is it becomes a checklist type thing, and we want to avoid that at all costs. But we also, you don't know what the patient's understanding when you ask them questions using medical jargon, so it's much better to put it into a patient-centered, everyday English, simple English type version. So that's what this card's about, and it's there as giving them some of the questions they may ask.
And the structure of the medical history, assuming that most of your learners will not be aware of any of this. So the medical history card then outlines the basic structure, the very basic content, and as John was mentioning, some of the questions that would be asked in relation to a systems review. We're asking that you not focus on system review questions at this time because your learners simply don't have that knowledge. That'll happen further in B term when students are actually focusing more on body systems. But it would be helpful for them to understand why those questions get asked and, as John was alluding to, how they should be asked so that they're not jargony. Okay, so the card is a good resource. So what students are going to be doing to this day, and what we're asking you to do in preparation, is we've put 3 samples of interviews on OWL for you to look at. And they are intended to be catalysts for discussion. They are not meant to be exemplary examples of what it is to do the perfect history.
We deliberately asked when these were being made that they not be perfect, that there are errors, there are things that we might say, well, that could have been done very differently, because it gives you the ability to discuss around that problem. So the residents who did these were very, very good at doing this. They've done a good job. There are all sorts of little problems in these histories to identify. They shouldn't be taken as, oh, that person doesn't do good interviews because they were set up not to be perfect or good interviews.
Exactly. And so have a look at the 3 interviews that are on now. And then what we're going to do is ask you to choose 2 of them that you might want to preview with your learners. Feedback from students in the past year has indicated that this particular activity is very valuable. Getting to see a medical history done, having an opportunity to critique what they might want to do a little differently is actually very helpful. Okay, so please view 2 of the interviews in your session. You've got 2 hours to do so you've got lots of time ahead of actually viewing your videos to discuss the content of the history, how one organizes it, why one does it that way, how it may look different perhaps with different patient populations, and to then actually view your histories and then to have further discussion about them.
One of the other things that we're hoping you'll be able to bring out in this is a bit about the cultural piece here as well, so that the students start to think that if they're using a patient-centered clinical method, a lot of the cultural information, the things that make us different, should come across in learning the patient's feelings, ideas, expectations and function. And therefore, they should start getting that information rather than worrying about what happens when I meet someone with a different culture.
Exactly. And one of the concerns that our students have is, so what happens if they're interviewing a person who perhaps has come from Saudi Arabia? Could they be asking things or saying things that are potentially offensive? How do they know what's important to that patient and what's relevant in relation to their medical care? if one is using a patient-centered interview technique, then the culture of the patient is probably not as important as the technique to elicit information. Every patient is unique, and the patient-centered method assumes that the physician is going to explore what's important to that particular patient. And as we said, their feelings about things, their ideas, what they were expecting, who might be, assuming a care role in that family, who perhaps makes decisions even as well, and how it's affecting their daily life. They may have very different roles in their life that we're not aware of, or very different constraints. So it's not about knowing everything about a different culture. We cannot do that. But it's about having an interview technique that will allow you to elicit information that would be important.
And we've got to be careful about not labeling cultures as visible minorities, because there are very different cultures within different groups.
Yes.
Someone who looks amazingly white Anglo-Saxon Protestant may not be, may be from a very, very different background, have very different values. Someone who looks coloured, Indian, or otherwise, may have been culturalized to Canada for generations and behave just as others. So, easy fixes here by saying, oh, they're obviously Arab, therefore I've got to deal with it this way, doesn't work, because that may not be true. They may look that, but that doesn't mean they are that.
Yeah. The premise here is that we are all raced, we are all cultured, we are all gendered, we're all sexed. But we all have a different place. And it's about location. So every one of us has a different, potentially, belief system based on ethnicity, which is often invisible, and where we grew up. So does the person who grew up in a small village have the same kinds of beliefs and practices as somebody who grew up in a large center? Now you move that across the ocean. John grew up in Scotland. I happen to grow up in Toronto. We have very different belief systems and practices, and by virtue of our professional backgrounds as well. So these are all factors that we want our learners to become sensitive to, and we're asking you to facilitate a discussion about this. So it's about asking learners to also reflect on their own cultural location. So how do they feel that their position as a healthcare professional could be influencing the interview? Okay. How do they feel about interviewing someone who may be that racialized other, someone who has a different skin color? How do they avoid stereotyping? Very important. So we often make assumptions that people have different belief systems, and we can be very wrong. So we need to ask questions that get at belief systems. The other fear that learners sometimes have is that they're going to offend somebody. They're going to offend a patient. They're going to walk into a room, extend their hand, and the patient will be uncomfortable with that. What do? Okay? There's nothing wrong with that. It's about being curious and asking, I'm sorry if I've offended you. Can you tell me what would be an appropriate greeting in your culture? Very easily to pick up on that and learn from your patient. Okay, so history then includes a dimension that is patient-centered, that is also, therefore, culturally sensitive, if it's being done in a way that is patient-centered. Okay? So that's what this particular tutorial is about. And it also prepares learners for the next session when they're going to go back into the Learning Resource Center and actually practice interviewing SPs again, this time integrating content of the medical history with the process skills of the Calgary-Cambridge Guide.
We've got to be very careful, however, because there's a big danger of content overriding and driving out a lot of the processes of communication skills. So you lose good processes because people become so focused on content. And that may be something you see in some of the interviews and you can bring up with the students. Exactly,
and that's often evident in the closed-ended questions about disease. And we do talk about what's the difference between disease, what is the difference between the illness experience. That's patient-centered interviewing. And again, just to review, that the disease is the biomedical. It's all of the symptoms, presentation, all of those concerns that one has about the presenting complaint, alleviating factors, aggravating factors, onset time, duration, intensity, all of those things. Those are important questions, but they need to be balanced with the illness experience questions of the patient. So tell me how that's affecting your life. Are you sleeping? Okay, how is it affecting your work? Are you able to work? What are your ideas about what might be causing this? Okay, those are the questions that get at that culturally sensitive dimension of an effective interview. Okay.
So thank you. We'll be back to discuss the second
Next session.
LRC session shortly.
Okay.